closed rhinoplasty. So I call my talk is a Dallas closed rhinoplasty. So I took a permission from Dr. Rorik to present about his Dallas technique. Surgeon will do closed technique. Before that, when I was doing my training, the surgeon who I work with, they think that rhinoplasty is not predictable. So usually they call it like Christmas present. So you don't know. You just do whatever excision medical technique. The problem with Dallas is an open technique. So basically, I was doing open technique till 2014. So I was so much convinced by the open result. His result is really awesome. So I thought because he has an experience, more experience or so, no. He told me at that time, I think the problem is with the technique. So the close is far much superior to the open technique. And this is the time I tried to do a bit of close technique. And with time, I get convinced that the close technique is more superior to the open technique. Having said that, I think I'm doing what they call it and we have all this discussion about close versus open technique. So, open, better exposure, better visualization, predictable results. This is the way they present it. This is what they call rhinoplasty paradox, in which usually for us as a surgeon, we see the skeleton, we work on the skeleton. The patient will see the envelope or the skin. And the problem, we make perfect, beautiful skeleton. Everybody's doing rhino, he knows about this, and then maybe 3 months, 6 months down the road, you see this deviation, there is more scarring, the tip is not. Can Dallas maneuver, all the maneuver of Dallas course, could it be done close? And my answer is yes. So the misconception is, you start with the open technique, like for a year or 2 or 3 years, because of the better exposure, and then you compare to closed technique. It's very difficult to teach the resident the closed technique because it's really closed. I don't think this is correct. Still, you can teach the closed technique in the same manner as open technique with the same principles. For me, I compare the open technique with the closed technique, like open, like cholecystectomy. Long time ago, when I was resident, I was doing open cholecystectomy, in which they kept everything's open. Then everybody's doing the laparoscopic technique. Only small or minor deformity is amenable for the closed technique. I don't think this is correct. Before you see the result, open technique 6 months to 12 months because of the amount of scar. % less dissection in the subcutaneous plane of closed technique compared to the open technique. So there will be less scarring. So I think that we should challenge this idea about what we call it wide dissection or wide exposure, because wide exposure. Yeah. So we can see the attachment in the picture, the right picture of the skin there's attachment between the skin and the cartilage. So we need to preserve this attachment. If we do extensive dissection, the area will be filled up with swelling and then scar tissue, and the patient will end up with a big problem down the road. Also, we need to preserve the ligament. The tip I use the same. Usually, I use the same technique as an open technique. It's going to be closed. So we can do fat removal or defattening, cephalic rim excision with minimal exposure. If you notice, this is limited exposure compared to the open technique. Shield graft. Also only a tip graft, and usually the amount of time now with the experience is far much less compared to the open technique, as I mentioned. Also we can do all